started with our housekeeping here. And as a reminder, this session is being recorded. The entirety of the session, with the exception of the case scenario, will be recorded for educational and quality improvement purposes. So by participating, you are consenting to being recorded. You're welcome to leave at any time if you would not like to be recorded. And now that we've been in post-pandemic mode for a while, you probably already know how to change your name or raise your hand. Here in the echo session, you're welcome to unmute and contribute. Don't feel like you need to raise your hand, but you are welcome to if you have a question or comment. If you do need to rename your profile, you can message a hub team member. It's those of us with the echo background, and we can help you figure out how to do that, or you can follow these instructions here. And as a reminder, because this is an echo session where we're talking about real world scenarios, we want to make sure that we're protecting privacy. We're talking about experiences that we've had or situations that we're dealing with. So when you're sharing information about another person, please avoid any identifying information, which includes their name, their initials, first, middle, or last name. Don't identify any of their family members, friends, coworkers, or share any information like email addresses. Do your best to make sure that we're not sharing any of that identifying information. If you have a question about something that you want to share, feel free to message one of the hub team members and we can run that by us. And as a reminder, this is an echo session, which is intended to be a very heavily participated in session. It's an interactive community where we all come together, we go through information, and then go through a case scenario together. So at some point, you will likely be asked to contribute or comment, especially during the case scenario. These sessions run a lot smoother when we have participation from our participants, and that's why we hold these. So please be prepared to share something, at least in the case scenario. And if you have a case scenario that you'd like to share in a future session, or if you'd like input from the ECHO community, reach out to me. We have our MHIDD email that I'll share here in a minute. We would love to have a case scenario from one of you all. Like I mentioned, we'll have a case presentation at the end of this session, but first we'll start out with a didactic presentation. This is a community of practice and a knowledge sharing type situation, so please share. Here's that email if you'd like to share a case study to review in one of our sessions. I will drop that email in the chat as well. If you would like a certificate of attendance or a CEU certificate, we have CEUs through the Utah Social Work Association. I apologize for the June session. If you requested those, I was a bit slow getting those out. I sent those this morning. If you didn't get that, please follow up with me. I'll make sure you get that by the end of today. And for the July session, if you would like a certificate of attendance or a CEU or both, you'll need to fill out the survey link, which we'll drop in the chat here. That will give you the option to select whether you want a CEU, a certificate of attendance, or both. It'll have you input your information and we'll send that to you. We do have a Canvas page if you'd like to follow up with any of the materials that we share. We have the presentations and recordings on there, as well as the case scenarios we summarize, and I post that information there. You do have to register for the Canvas page. So if you would like to do that, you'll need to send an email to the mhidd@aggies.usu.edu email that I dropped in the chat, and we can help you get registered. We do have some social media pages if you'd like to follow and keep updated. We have information about other echoes that we share as well. We have a Facebook and an Instagram. We have this QR code here that will take you to our social media as well. Our next session will be August 14th. That one will be evidence-based approaches to providing mental health services for adults with IDD or intellectual developmental disabilities, part 1. We will have one mental health provider who provides some information about how they provide services, and the part 2 that will happen in September is another provider that will give their input and their approaches. And today our presenter is actually here from the Institute for Disability Research Policy and Practice, who works on our team with us. He is a licensed marriage and family therapist. Yeah, I will share some more about himself here in a minute when he presents. So Ty, I will turn that over to you.
Awesome. Thanks, Rachel. Give me just 1 second to pull up the screen here to make sure I have it running. Right, so everyone can see my regular screen. Is that right? Then it should be changing. All right. Hello, everyone. Happy to be here today. I'll jump in and introduce myself in just a second, but we're going to be talking about behavior as communication in the context of mental health concerns. And it's a loose-fitting title for how do we understand mental health concerns through different types of communication. And we'll talk through that and hopefully maybe spur some new thoughts or maybe new ways to look at contributing to mental health treatment and intervention and even prevention. So before I get started, I just wanted to introduce myself. I'm a research assistant professor here at the Institute for Disability Research Policy and Practice. My faculty roles in the Department of Human Development and Family Science. I'm also a licensed marriage and family therapist practicing here in Northern Utah. I've been doing therapy. This August is my decade mark, which feels like a long time for I'm only 31. So I've been practicing since I was 21 and have learned quite a bit and got into working with folks with developmental disabilities probably the last 3 years as I was hired here. So we'll talk a little bit about those experiences, but more so related to the research I do in prevention. I'm also a family member of an individual with a developmental disability. 2 of my cousins are individuals with Down syndrome, and then another one of my cousins is an adult that has been diagnosed with autism spectrum disorder. And I am a person with a lived experience of a mental health concern. So I've had a diagnosis of PTSD in my life and have gone to therapy for about 10 years is how long I ended up going for. So I have a few different angles in the way I approach this work. Some of it's from the provider lens as a licensed marriage and family therapist. Some of the info I'll pull from today is from my research lens and the research that I've done in my time as a research assistant professor. And other of the experiences are just my personal experience and lived experience working through the service system. So I think it's important to have all facets of the mental health field to be able to talk in a way that can actually help us navigate and guide through the system. So just as a brief introduction to what we're going to hopefully be going over today is first is mental health literacy. So that's really the heart of what I'm going to be talking to y'all about today is not intervention, but actual prevention. And I'll explain that on the next slide. But we're going to be talking specifically about something called mental health literacy. Mental health literacy was actually developed by a gentleman named Dr. Anthony Jorm out of Australia. And it's actually proliferated across the entire, globe, really, with the biggest program in the United States being called Mental Health First Aid. But the idea behind mental health literacy is preventing mental health concerns or mental health issues from occurring or worsening. And we'll get more into what that means today and how all of us in this group can play a part in that. I'm also going to talk to you a little bit about seeing humans as part of ecological systems. I think as we talk about mental health concerns and working with different folks that might experience different components of mental health, is that we forget that we're part of larger systems, and those systems influence us, and those systems of care also influence how we might be feeling or acting. But if we understand that system we're living in, we can better understand what the behavior might actually be communicating. So I'm going to challenge us a lot to be thinking as humans as part of dynamic systems rather than just people that are operating in isolated events. And then just walking through a little bit of a skill set on how to actually identify mental health concerns. As you can see, we're already 5 minutes into 30 minutes and we have a lot to go over today. So it'll be really more of an introduction to some of this work, but hopefully you'll leave today with maybe 1 or 2 skills where you feel like, I can have a better understanding of how to identify mental health concerns and what to do once I've seen them. So this idea behind prevention and intervention, I wanted to start there because it really informs this work and how we think through it. So mental health literacy or prevention work can be best understood in my mind by thinking of a river. So I've included this picture of a river here in Glacier National Park. And if you think of intervention work, it's often like us wading out into that river and pulling folks out of the stream after they've already gone down through the rapids, gotten bumped up and bruised, and might really be struggling for air. And so us clinicians or interventionists might run out into that river, throw them a lifeline, or try to pull them out of the water. Whereas preventionists might look up the river and go, hey, I can see all those folks upstream 100 or 200 yards jumping into the river. Has anyone ever thought of walking up the bank and maybe trying to find a way to prevent them from jumping in? So the main idea between these two concepts is that prevention is we're hopefully getting to people before their issues have occurred or are worsening. Whereas intervention is going, we already know these issues have kind of set in, or mental health concerns are pretty active, and we're trying to find them or work with them to develop new skills that might help them get out of the river. So when we think of this prevention model, it can be used from anywhere from mental health clinicians like myself to teachers, paraprofessionals, really anyone that comes into contact with someone that might be experiencing a mental health concern. Some of the literature talks about that as in the form of gatekeepers. I don't love that terminology. I think it's more of like our first responders. So the people that are most likely to come into contact with someone, which could be, like I was saying, the paraprofessionals and teachers are the easiest way to think of that. So as we go through our content today, I'm really taking it from that prevention lens rather than an interventionist lens. So as we talk and think about mental health literacy, what is it? Well, similar to like concepts of health literacy, I think the easiest one to think through is diabetes management. There's some basic education around what diabetes might be, and then how to manage your glucose levels, and maybe getting some education on your glucose monitor, and then learning just about basic activities of life that may help you manage diabetes. Well, mental health literacy is in a very similar vein to that, is we try to help educate folks on what are the different components of mental health and how that might change by different interactions that we have in life. And then if we are experiencing a mental health concern, what do we actually do? Our team here at Utah State really thinks about mental health literacy in these kind of three different processes. So it's like identifying mental health concerns, locating evidence-based resources, and then responding to mental health concerns or crises. And within each of those different areas, we can really help someone grow their knowledge, maybe develop some more confidence in being able to practice the skills, and in doing specific behaviors that might actually apply to identifying, locating, or responding. So what that might look like is being able to identify what warning signs of depression are. So that could be your declarative knowledge, feeling confident in your ability to ask questions to someone that would help you clarify if they're experiencing a mental health concern. That would be self-efficacy related to identifying mental health concerns. And then actually doing the behavior, asking the questions, or maybe having a conversation with someone about their mental health. So as we continue to talk about mental health literacy today, this is what I'm referring to, is the ability to identify if someone's experiencing a mental health concern, then being able to locate resources that might actually be able to support that person experiencing a mental health concern, and then having the skill set to be able to talk to that person to help them engage with getting access to resources, or maybe even de-escalating crises. We won't go fully into depth on any one of these domains. Really, what we're going to focus on is identifying today. But just keep in mind as you're thinking through kind of building communities of support or building up systems of support, that educating everyone, as far as like individuals in the community all the way up to your program facilitators, it can be really useful to have some mental health literacy so we know what we're looking for and just have a more educated system. Mental health literacy has been delivered in lots of different programs, and I'll just give you a brief snapshot before we jump into how do we actually do these skills. So the most common mental health literacy program in the United States right now is called Mental Health First Aid. It's developed by Jorman Kitchener, and it's really sponsored heavily by the Substance Abuse and Mental Health Services Administration. Really what the entire idea behind Mental Health First Aid is to identify, understand, and respond. They really focus on helping increase people's ability to identify mental health concerns that are happening for folks, understanding them by decreasing stigma related to that, because that's often one of the biggest barriers to seeking care. And then actually knowing how to talk to someone that might be in a crisis, might be experiencing trauma-based responses, might be engaging with substance abuse, or may even be suicidal. So learning how to respond to those. These are skills-based trainings, and they're where teachers really engage with participants to help them learn the skills and actually respond. So it's not just knowledge for the sake of knowledge, it's knowledge for the sake of action. These types of programs have also been adapted to teens, like Youth Aware of Mental Health and 3-hour role play, interactive workshops with booklets, or in college curriculums like the Mental Health Awareness and Advocacy curriculum that we created here at Utah State. So the cool thing about these programs is they can be applied to lots of different systems and can really improve that mental health literacy for varying types of folks. Anything from college students to youth in elementary school, up to service professionals and HR leaders in big corporations. And what we consistently see from these programs is that they were able to increase many different outcomes, including knowledge, self-efficacy, self-help seeking skills or service seeking skills, basically just actually calling a therapist when you've identified you might be experiencing something. And also being able to correctly identify mental health concerns when they're happening. And all of these skills collectively, we think, can help drive some prevention-based models. So now we can start sneaking in a little bit to the, well, what are the actual skills? So here's my first question for y'all today, and hopefully we can jump into the chat just briefly. But I'm curious, how do we know when someone might benefit from mental health services or supports? Can y'all throw maybe a couple of ideas there into the chat? Is what might you look for? How do we know? And if you're seeing the foreshadowing, you should start thinking, oh, that's the behavior is communication, right? So how do we know someone might be experiencing a mental health concern or might benefit from services? I'll wait till I see a couple of things there in the chat. I've got it open. This is always when I hope and pray that the IDRPP folks will throw in things. All right, I won't wait too long. Okay, behavior outside of baseline. Yeah, change in baseline behaviors. That's one that I often see. Everyone said it all at the same time. That was eerie. So yep, we have change in baseline behavior. So that's one. I'm also curious what others might be. They may actually ask for the help, maybe talking about things. As we keep going through this info, that's really the overall question that I want to help drive home is how do we actually know when someone might benefit? And I don't think there's a specific, here's the exact answer, but I'm going to give you some of the ways I try to think through how do we might know if they could benefit and what to look for. So the first place I like to start is really thinking of humans as kind of this ecological system. So growing up, my family owned a pheasant farm and on a larger dry farm that also had a dairy farm on it. So I spent a lot of time outside watching animals and plants interact with their natural world. I think it's been really fun this year because we've had a really busy spring and it was snowfall all the way up until April here in Cache Valley. And that changed our ecosystem and how our plants are responding to it. And if you slow down enough in life, you can start to see this in humans too. Our ecological systems are different levels of the world we interact with, which is often explained through a boring theory that I won't go too much in detail with. But thinking through things like individual factors, like maybe how our relationships may have shaped our early experiences, things like attachment, the ways we interact with our community, that may be through our school systems, that may be through friends and peers or family or resources that we might have, the current culture we live within, and the current time or age we live in. Each of those factors are influencing how we interact with the world and shapes our mental health. And it can be a really helpful model to think through things as we're trying to be curious if someone's change in their baseline could actually be due to a mental health concern. So from that big model, I start trying to think through, well, how do I actually detect maybe changes in someone or changes that I see, and then ask questions about it to determine, is this something that could be related to their mental health? Well, I like to think of this analogy or this metaphor of a garden, and understanding behavior really is like gardening. So this weekend I was out, this is actually a picture of my grandpa's garden, and I was out there and his peppers were really, really struggling. This was like 2 years before, and they're not struggling in the picture, but in his current garden, they're really struggling. And as we started looking around his garden, we got a lot of clues. Some of it was maybe he was getting too much water because he was flooding from the top of his garden to get the tomatoes that were below the peppers. Some of it could be that our temperatures haven't been as hot this year thus far until the last week. Some of it could just be that the soil might have been different. And we were able to start generating working hypotheses based on the overall system. We're saying, hey, in this garden, there are lots of different things that might help a plant grow, thrive, or maybe not grow and be stunted. And our job is to get really curious about the overall environment to better understand the behavior that's happening and to understand why it might be a useful behavior. And so from there, we can start putting together hypotheses of like, this might be why this behavior is happening and why it might be causing a person distress, which then leads to some mental health concerns. So the next question that you might start thinking about then is, well, when does the garden actually need attention? So I'm curious for y'all, like, when do you think the garden or someone's behavior might need an attention? We've said, well, change in baseline. What else? So someone else said they recently experienced Emily recently experienced a traumatic event. What other things might make you go, the garden needs attention or someone's behavior needs attention? For me with the garden, it was like when my corn started turning light green and I found out, I have a broken sprinkler pipe under there. All my nitrogen's gone. That was an indicator. So someone's actual physical appearance changed, and it made me get a clue of, I might need to address this. What other things? Inability to engage in typical self-care activities. Yeah, thanks, Matt. Might be you stop engaging as much socially. For me, it's often irritability. Like my wife will say, you're really unbearable to be around because you're ornery. So that one. Yeah, wilting, or in humans, it's less self-care. Yeah, so things that we do that aren't helping us nourish or grow. Yeah, so we might see less values-directed behaviors, what I really like to get down to. So doing things that we actually care about, we might see those happening less. Yeah, some withdrawal. And so typically the way clinicians think about this or in diagnoses, I don't necessarily think that is as useful as for community members, but I threw this up because as you can see with depression and anxiety, sadness, and kind of this worry or fear piece, we kind of refer to these things as general distress. So we've talked about that change in baseline. Y'all are starting to map out some of the social components where we become more isolated. Those are all indicative of what we just call general distress often, or the depression and anxiety diagnoses. So if someone is, in my class when I'm teaching, one of the things that we start trying to do is just notice the difference between normal feelings of sadness and persistent feelings of sadness. So for depression, that might look like sadness that's come on and has stayed persistent for longer than 2 weeks and has a few other things that it's accompanying it. So for me, again, I'm an irritable person. So when I'm feeling depressed, I might actually have irritability that joins the show, might be less likely to do things I care about. For me, it's a lot of the times I write less for some reason. I just get really kind of down. I might be numbing myself out on the phone more. For some folks, they might have thoughts of suicide or death, some increased tiredness, and it's just these general symptoms. The wild thing that I think is important to kind of notice is that everyone experiences these things because it's a range of the human condition. We all have feelings of sadness at times, and more likely than not, we'll know someone that will go through clinical depression in their lifetime. And so it's when these things are joining together and it's getting in the way of someone making a values-based decision or valued actions over time, that's when I start going, oh, there's the change in baseline. They're also experiencing these things that are indicative of depression. They might be having a mental health concern that could benefit from some treatment or for some resources. Similar with anxiety, some of the things we look for again is the irritability, especially in teens. They might have trembling, a lot of worry-based thoughts of, oh no, what is this person thinking? What if this happens? What if that happens? Contingency planning, walking through, 30 different options, feeling nervous or powerlessness, or maybe even feeling really uptight and on edge regularly. And a lot of those physiological symptoms. So with anxiety, it's more of this like fight or flight type response. And it's really saying, hey, go, go, go. Whereas depression is saying, slow down, slow down, slow down. Let's ruminate. Anxiety is saying, go, go, go. Let's ruminate, but keep going. Both of these things share commonalities. We won't get too much into that. You can see them here in the picture. But really what I try to get folks to do is just noticing, hey, when these experiences pop up, which are very normative for humans, but they're also getting in the way of the life they want to live, that's when they might benefit from having conversations with someone to get connections to resources. So some things to keep in mind as you're trying to figure out, is this depression and anxiety like a mental health concern, or is this just regular feelings of sadness? Well, guess what? As a community member, I actually don't care if we get to that diagnostic point. I want to just be able to recognize these things while keeping a few things in mind. So are these symptoms or these behaviors getting in the way of the life the person wants? So for me, who's experienced a lot of anxiety through my life, and especially during COVID, I started having some of those feelings of like agoraphobia come back in, especially where we couldn't go out into stores. I remember when stores reopened, it was really, really hard for me to go into stores. And it was something that I had to expose myself a lot to. Well, that did get in the way of the life I wanted to live because I wasn't going out in public or taking my kiddo out to the store or doing things that were engaging in public spheres because I was so scared of being back out in open spaces and around people again. So yeah, I was getting in the way of the life I wanted. So might have been able to benefit from services in that way. I also try to get really curious on what strengths is the person exhibiting, even though these painful pieces are there. So are they staying connected with people they enjoy? Are they actually finding ways to deal with a lot of the stress through some self-help strategies, or maybe through connection, or maybe even they're doing some avoidance things, but it's actually working in a way that's not messing up their life more? I try to find some strengths that we can cultivate. Change in baseline, y'all got that one. That's something I look for. And what are all the possibilities this behavior might be suggesting? That's especially important when you start considering folks that might have different communication strategies and need assistive technologies to communicate, or might actually have different worldviews. So I work with a lot of folks that have been diagnosed with autism spectrum disorder. And as you talk to folks with social relationships, some of my worldview is different than the worldview of my clients as far as social relationships. So my assumptions on, hey, you seem more isolated, that might be them being very socially connected through online mediums. So you have to stay curious and not get too hung up on your own worldview on how reactions or a baseline should look, and get curious with them and ask them, has your baseline actually changed? And what are the many different reasons why these behaviors might be showing or not showing? And then are there ways I can actually help enhance communication via assistive technologies for folks, not only with developmental disabilities, but for teenagers and kiddos? A lot of the times we don't have the language to actually discuss emotional health. So that might be getting things like an emotion wheel, talking through those, and really just starting to create language around it to even be able to assess if there's a change in baseline. So collectively, these things, if we start understanding some depression and we might understanding some anxiety, those are the biggest general distress umbrella that we can start going, hey, we can start getting people before they're thrown into the river by noticing these things are warning signs for mental health concerns. And if we're able to actually get those folks connected sooner to resources or social supports or community supports or anything in that ecological system, we might be able to actually prevent mental issues from occurring or worsening. So now we'll jump into a little bit of practice, and this will actually be the last piece that we can go into today, and I'll stay around for questions if we have them. Oops. Yeah, what type of changes have happened to the ecosystem recently, which is someone said earlier related to trauma events? Has there been something traumatic that's happened? But let's actually practice with a little bit of vignette and try to notice maybe some of these things we just learned about. So John Smith is a 30-year-old married male who feels down most of the time, and he's experienced frequent intrusive thoughts that he's not good enough, despite personal and professional successes. He tries to overcompensate for his thoughts by taking on more than he can handle, which leads to failure and furthers his feelings of inadequacy. His wife suggests that he seek help after finding him crying. And this following is an actual excerpt from his intake interview with his psychiatrist. He mentioned him feeling pretty worthless and having felt that way for a long time, for actually over 10 years. Feels normal to be down. Sometimes I start to feel better, but it never lasts. I feel bad about my life most of the time. I don't think that I'll amount to anything, and I might never be successful at work. I feel exhausted all the time. I have trouble sleeping. I've been waking up in the middle of the night and can't stop thinking about all my failures. Lost weight in the past few months. Food just doesn't taste as good as it used to. I feel hopeless and often have trouble concentrating when I'm with my family and friends. Maybe I'm just pessimistic. So take just a few seconds and thinking back to the last slide with depression and anxiety and maybe some of those things I try to keep in mind. What would you be curious about with John, or what might you be noticing he is experiencing based on this text? Take just a couple of seconds, maybe throw some of those ideas in the chat. The first thing that I notice is that if you had just made friends with John, or you were a provider or maybe a paraprofessional just working with John, he explained that these things were going on for 10 years. So the baseline piece may not be as useful here because he may have been experiencing this baseline for a decade. So one of the things that I'll encourage folks to do is like get curious about, has it worsened within that time frame, and or was it ever different? Is there a time they can remember having a different mood state? Anything else y'all notice in that vignette? I can walk through it here in just a second too, but curious if there was anything else y'all noticed. Feelings of worthlessness are noted there. Taking on too much, lack of appetite. Yep. Oh, I didn't even notice that in the last few months versus the previous amount of years. Yeah, good catch. I didn't notice that. Yeah. What would you do to feel good enough? That's a good way. Chasing a feeling, I think, is really important. If someone's chasing a feeling and trying to replace it, they'll often explain that, hey, that internal sensation or that internal behavior is something I want to get rid of or get away from. Yeah, a lot of talk about just feeling down and feeling like no matter the efforts that they put in, it never goes in. Ooh, I really like that question. I wonder what triggers it. I think that's a really useful ecological systems approach. So what's interesting and what was really hard about trying to find vignettes online was that next to none of them took an ecosystems approach. It really talked about an individual and their individual states, very myopic lens, rather than seeing the full system. So I would be really curious too there. I'm like, what else was going on in the system that might be helping or making the depression worse? We don't know about job, family relationships, anything like that. Anything else y'all notice? I'm not noticing anything from what we talked about too. So I guess I'm curious here is like, could John be someone that benefits from mental health supports? Well, his wife thought so and facilitated it. And so I think the last piece here would be like, well, when do we determine if someone actually benefits from resources or not? And in the literature, like around self-help or help-seeking behaviors, we actually see that folks will sit around and not seek help for their mental health concerns because they often don't realize it's actually a concern that they could benefit from seeking help. So the way I boil it down to students that I've taught over the last 5 years here at USU is that if you feel like this is getting in the way of the life they want to live and they're not able to take value-based actions and create a life of purpose, I go, probably would benefit from some type of resource. That could be connecting with community groups that help find purpose. That could be helping connect to social groups that will help develop a thriving social life. And that might be through mental health treatment with like a therapist, psychologist, someone to that effect. So the idea of mental health literacy here is to get better at screening and identifying people that often sit around and don't seek help because they didn't realize their issue was as bad or could benefit from services, to be able to increase the likelihood of them getting access. So by educating ourselves and knowing and increasing our mental health literacy, we might be able to actually prevent those things from occurring or worsening before we ever even actually have to intervene. And that, I think, is pretty close to my 30 minutes. I hope I didn't keep track. So I can just turn it over to questions. We obviously didn't go over the locating resources or responding to someone. We do that more in our expansive trainings, usually in a 30-minute to 1 hour time frame. We can get really good at helping folks identify mental health concerns happening, and then we need to teach them those other skills. That being said, I think this should be useful, and if there are questions, happy to answer them right now. Uh-oh, I lost my chat too. Let's see. Ooh, my favorite though, no questions. So I'll turn it back. I don't know who I'm supposed to turn it back over to. You, Rachel, or is it Janelle? I don't know who's facilitating.
Yep, you can turn that back over to me. Thank you so much, Ty. Really appreciated having you. Thank you for sharing all that. It's very useful information.
Yeah, no problem. Thanks for having me.
All right. With that didactic presentation done, we're going to move into our case scenario. If you do think of any questions for Ty, you can send them to me or Ty. I don't know if you've already shared your email in the chat, if you're open to questions via email, if anybody has any follow-up questions. I will go ahead and pull up our case presentation for today. All right, I'll be providing our case scenario today. I'll go over some details. You can ask any clarifying questions. And then what we're going to do today is split into 2 breakout groups. They'll be a little bit larger than we've done before. If you've attended previous sessions, each group will have 2 questions to discuss. We'll come back after 20 minutes of discussion and we'll have 4 questions to review as a group. I will take notes and summarize all of our case recommendations, and that will be posted to the Canvas page. So this case, to give you where it comes from, you may already know if you've attended a previous session, I used to manage residential rehabilitation or supported living services. And this is an example from that background. In this case, there was a 55-year-old white male with intellectual disabilities and significant communication issues who lives in suburban Utah. They had just moved into a group home receiving supported living services 24/7. They had no family support because they were previously living on the street and they were referred to services by a social worker. We're unsure about their medical history. They don't have any documents with them, and there's poor self-report. As far as the primary areas of concern go, this individual is new to the group home, and gathering medical and health history has been challenging because they have a lack of natural supports and there's poor self-report. They're unable to recall their medical history very well. Throughout the first week in supported living services, they have attempted to elope several times. Typically when staff's back is turned. When asked why they tried to elope, he responded, "I'm not safe here." Direct support professionals have noticed scars on the individual's arms and legs that indicate a history of self-harm, and direct support professionals are concerned that the level of supervision is not sufficient for this individual's needs. The hospital will not provide a psychiatric hold because the individual is not deemed as a safety risk to themselves or others. The goals in this case are to provide thorough documentation of the first week in services to medical and state professionals, connect with necessary medical professionals, address that the individual's concern of not feeling safe in the group home, and identify next steps for potential medication and or behavioral solution. And the barriers in this case, as I've mentioned already, there's poor self-report and no natural supports to provide context or history. And the risk of elopement is a concern in community settings, especially with the current staffing ratio provided. So the 4 questions that we'll be discussing today based on that case, and once we go through these questions, if you have any clarifying questions for me about the case, if I have the answer to that question, I'll provide it. This first one is, how can direct support professionals be encouraged and supported to document all information that may be relevant to medical and state professionals? What medical services / assessments may be needed for this individual? How can direct support professionals and or case managers address the individual's report that they do not feel safe in the group home? And how can staff support independence and autonomy while taking into consideration all of these safety concerns? Are there any clarifying questions about this case? You can drop those in the chat or feel free to unmute.
Rachel, any idea on how long he was in the community, or how long he was homeless?
Based on self-report, he reported having been homeless for 5 years. All right, if there aren't any other clarifying questions, Sarah, we can move into breakout groups.
Okay, I've opened those up. If you could just join the room, I pre-assigned everyone to them, so it should be pretty easy.
Okay, welcome back, everybody. We'll give it a second because there might be a few more people. Sarah, do you know if we're all back? I think we lost a few people at the hour mark, but
Yeah, it looks like everybody that is still on the meeting is out of the breakout rooms. Breakout rooms are closed. So
okay. Awesome, thank you. All right, so we have about 25 minutes left. What we're going to do now is go through as a group the recommendations or comments that we came up with going over those questions. For those first 2 questions, let's look at the first one. I can share my screen again, so we've got those up for reference. So this first one was, how can direct support professionals be encouraged and supported to document all information that may be relevant to medical and state professionals? Does someone from your group who discussed these want to share? And I will take notes as we go through so that I can summarize and send these out after our meeting today.
Sorry, I was talking to myself on mute. I wasn't smart and didn't assign anyone else, so I took notes and facilitated. So I'll report out on what we discussed, and then anybody who is in my group certainly chime in if I didn't get it right. But one of the first things that came up from Emily was that a lot of times folks who are direct support professionals, right, they're there because they care, but they're not always as educated, right, about different systems and different options and everything else. So really guidance from supervisors and coworkers who may be more experienced, who may have professional degrees, certifications, whatever, on how to effectively collect data and specifically what to look for, would be important. And I think, really that boils down to, right, providing training for direct support professionals on how do you effectively document and capture this information. And a lot of times I think that's overlooked. We talked about, a lot of times these direct support professionals, they want to be there, they are motivated, they have good intentions, and all they need is oftentimes to be pointed in the right direction. But I think making sure that they have access to professionals and to experts to help them understand what might be happening would be important. But then we also talked about education about warning signs, kind of what Ty talked about. We also talked about, Ashley brought this up, that it's important to provide direct support professionals with opportunities to get to know the clients and to maybe understand more about a client's background and their needs and preferences and what their different communication styles may mean, and really helping direct support professionals understand that behavior is a form of communication, and that when somebody is engaging in certain behaviors, they may be saying something about their mental or physical health.
Yeah, awesome. Thanks, Matt.
Yep.
Our group actually talked about this question just a little bit towards the end of our discussion. And similarly, we talked about providing training for DSPs on documenting behaviors, helping them understand what to look for and what should be documented. Katie mentioned technical assistance after training, so that ongoing support after any initial training, making sure, do they have any questions after that training? Do they feel that they know everything they need to know to document and understand that? Also, a comment from someone in our group was to remind the direct support professional and show them that they have one of the most important roles, because they're there, they see behavior firsthand, they are with that individual for several hours of a day. To have clear guidelines was also suggested. Electronic documentation, I'm actually not sure what the current status is as far as providers in Utah. I'm not sure if people are using paper or have moved to electronic systems. When I was managing services, we were still totally on paper. So I'd be curious to see what that looks like for a lot of providers here. Again, that regular supervision and feedback. So providing training and then also continued support. We also had a suggestion that was really important, is focusing on some peer support and collaboration. And I think this would go with what Ashley mentioned as far as really trying to get to know the client and their communication styles for sure. And I see Michelle added in the chat, taking notes and documenting could be critical, enabling the client to qualify for psychiatric help. Absolutely, making sure we have documentation to support that need for services. Okay, and our second question, what medical services / assessments may be needed for the individual? What about that?
That was our group too. So again, we talked about a lot of times direct support professionals may not be in a place to make those assessments. So having a professional or access to a professional or an expert is important. But we also talked about some form of PTSD evaluation because of the correlation between trauma and lack of housing, and what that, just some common patterns that we see there. Another thing that was brought up by Ashley was the importance of a full physical and dental exam and just kind of looking at a person's overall physical health. A lot of times behaviors arise as a response to pain or physical issues. And so, not knowing when the last time this person saw a dentist or a doctor would be a good indication that maybe they should go have a full sort of workup just to make sure they're not experiencing, right, a toothache or diabetes or irritable bowel syndrome or some of these other things that, may have pretty significant symptoms but are difficult to identify without a full workup. Then another one that I think was really good, that's not really what medical services or assessments may be needed, but Raimundo brought up that it would be important to reach out to that social worker and work on coordinating the care between systems. What background, what information, what context does that social worker who is working with the individual have? A lot of times, some of the challenges that come up with people with mental health issues and IDD is a lack of coordination between systems. And it often takes somebody who's proactive to reach out and to try and to actively coordinate that care. So again, reaching out to the social worker and getting any information they have. And then finally, we brought up some sort of an assistive technology, assistive communication evaluation to see if there's any communication that might help this person get access to technology that might help them communicate more effectively.
Yeah, those are excellent ideas. I especially like that note about contacting the social worker and making sure that that cross coordination is happening so that we have all the information that's possible. Similarly, I also took the notes and we'll share from our group those last two questions. How can direct support professionals and or case managers address the individual's report that they do not feel safe in the group home? We had some wonderful suggestions. One being working on establishing trust and building rapport so that individual feels comfortable to share, maybe more about why they don't feel safe, asking them what may help them to feel more safe in the situation, and then allowing as much opportunity for autonomy and independence as possible. So being able to make their own decisions, sitting down with them and working towards a solution or establishing some goals if they don't already have any. I like this note, trying to make it a net positive for the individual, because their history with individuals who are homeless or unhoused, there are a lot of things that go into that. So being able to explore that a little bit or take that context into consideration, see how that individual feels about their current living situation and why they ended up there. And then this kind of blends into the last question. I think these go along together really well. How can staff support independence and autonomy while taking into consideration safety concerns? So again, that point of allowing as much control over their decisions and their situation as possible. Making sure, one note that was important when we're working with people, making sure that we're using plain language. So when we're communicating, we're talking about things like mental health, discomfort, being uncomfortable in the situation, making sure that we're communicating in ways that they can understand. We also would like to provide opportunities for engagement with the group home members in ways that that individual enjoys. So exploring things that do help them feel safe, activities that they enjoy participating in, something that they would like to do that provides a way to connect with other group home members and staff, and seeing if they have any goals established with their case manager, what some of the more of that coordination of care, what's happening across all of those levels right now. That was a lot. Sounds like we had a lot of conversation across the groups over these questions. I have a lot of notes here that I've written down. Is there anything else as we've gone through these questions and talked about our notes that anyone would like to add? Any other questions, comments, or concerns? All right, if there aren't any other questions, comments, or concerns, I will make sure that I wrap up all these notes. They'll be posted on the Canvas page. And if you would like a CEU or certificate of attendance, be sure to fill out the survey link in the chat. I will say, if you're curious into how this case played out, the individual was eventually diagnosed with schizoaffective disorder, bipolar type. That contributed to, they wanted to live in a home, but they were unable to maintain employment due to the untreated mental health concern, which was contributed to extended periods of homelessness. Thank you all for coming. For those who especially stuck around beyond the hour mark, we know these sessions are a little longer than your typical training or meetings. Thank you so much for coming. If you have any questions, feel free to pop them in the chat or send me an email. I'll hang around for a few minutes to answer questions or follow up with anything. And we'll let you get back to your day.
Thanks, Rachel. Good to see you, James.